lacunar stroke is a subtype of stroke. It causes about a quarter of all ischemic strokes, so it's quite common. And it's thought to be due to a small blood vessel that runs deep into the brain, becoming damaged and abnormal, and then causing this deep damage in the brain. And for various reasons, over many years, it has become apparent that this is probably a different mechanism, different type of stroke to other strokes which are caused by, for example, atheroma in the carotid arteries or emboli from the heart. And at the moment, lacunar ischemic stroke is treated just like any other ischemic stroke. So typically, patients would receive an antiplatelet drug like aspirin or clopidogrel. They would be given antihypertensive treatment, and they would be given lipid-lowering treatment and lifestyle advice. However, a number of years ago, there was a big trial in America which showed that if you gave two antiplatelet drugs over a long period of time, that to patients with lacunar stroke, that it was actually dangerous. It didn't help them at all, and it actually caused bleeding. And also, that trial tested intensive blood pressure lowering versus usual guideline blood pressure lowering, and didn't find any benefit of intensive versus guideline, either on recurrent stroke or other outcomes, including cognition. So putting all this together, it kind of suggests that actually the usual way that we tackle stroke prevention doesn't maybe work as well as it should do for lacunar stroke. And maybe the problem is in the small blood vessels and in the lining of the small blood vessels, which get damaged. And so something which perhaps tackled the small blood vessel lining, the endothelium as it's called, might be worth a try. And that's what we did in LACI-2. Over a number of years with Philip, we looked at a range of possible drugs which have effects on the lining of these small blood vessels, and we narrowed it down to two drugs which are both already available and used for other blood vessel diseases, and for which there is some evidence on, and we know a lot about whether they're harmful or not because of this wider usage. And we set up the LACI-2 trial to test if one or other of these drugs, or the combination of the drugs, might help reduce bad outcomes. So the two drugs, one of them is called Isosorbide mononitrate. It's widely used to treat ischemic heart disease, so angina particularly. It's been used for decades in ischemic heart disease. And the other one is called Cilostazol, and Cilostazol has been quite widely used in Asia-Pacific countries like Japan, China, Korea, but it's not so much used in the West. In Asia-Pacific countries, it's been trialed in stroke prevention, and there's some suggestion that it may be helpful, particularly if given longer term, like over a year, and maybe in some hints that it might be more beneficial in lacunar stroke than other types of stroke. And also it seems to be less likely to cause bleeding. Anyway, so those are the two drugs that we tested, and we randomized patients to isosorbide mononitrate versus no isosorbide mononitrate, and Cilostazol versus no Cilostazol. And so you end up with four groups: isosorbide mononitrate alone, Cilostazol alone, both drugs, or neither drug. And all patients also got guideline stroke prevention, because that's what's in the guidelines at the moment. We can't go back on that. So our trial was done on top of guideline stroke prevention. So if you like, it was comparing the two drugs to best medical therapy, on top of best medical therapy to best medical therapy alone. Philip, perhaps I could pass on to you at this point to mention other design features.
So yes, Joanna's highlighted the two drugs. Just probably worth emphasizing that both of them reflect endogenous compounds or substances that the body would make, the lining of blood vessels would make. So endothelial cells will produce nitric oxide. And obviously isosorbide mononitrate is a nitric oxide donor. And endothelial cells also produce prostacyclin and also another substance, PDE2. And they work on a second messenger, cyclic AMP. And cyclic AMP is broken down by phosphodiesterase 3. And cilostazol inhibits phosphodiesterase 3. And so in the presence of cilostazol, there will be more cyclic AMP, reflecting endogenous production of prostacyclin. So these two drugs together are, if you like, amplifying these protective pathways. Nitric oxide and prostacyclin protect the endothelium. They have anti-platelet effects. They have anti-leukocyte effects. They relax blood vessels. They stop the contractile cells in blood vessels from becoming more rigid, and they have neuroprotective, or more widely, cytoprotective effects on cells around the blood vessels, so astrocytes, neurons, and so on. So these drugs are hopefully protecting the lining of blood vessels, but they're also going to have effects more distal to that. So as you've heard, it was a factorial design. Patients were treated over 1 year. They got into the trial because they had a Lacunar syndrome, and they had neuroimaging that was compatible with a Lacunar type stroke. So in other words, there wasn't a cortical stroke, a fresh cortical stroke, or a recent cortical stroke rather, and there wasn't some other stroke mimic. So they had to get in there with a Lacunar presentation. And then the primary outcomes, there were a number of different ones. The key one, if you like, was about, could you do this trial? And the key questions in terms of delivery of the trial are, can you recruit sites? Can you recruit patients? Can you keep patients for the year of treatment? Do the participants stay on their randomized drugs? Is it safe? Joanna's already alluded to problems in previous trials, particularly with bleeding. And then, of course, proof of concept. And the key interests of proof of concept were a composite outcome. So this is a grouping of events. So did they have another stroke? Did they have a heart attack? Did they die? Did they suffer cognitive impairment? And did they suffer dependency? So you add all those events together and get a composite. And then within those, we expanded those binary outcomes into an ordered categorical outcome. One was dependency using the ranking scale, and one was a fairly new 7-level cognitive ordered categorical scale that we've developed for another study, but have used in this particular trial. So I'll hand back to Joanna to give you the results.
Okay, thanks. So first of all, we had aimed to recruit 400 patients when we started in about 25, 26 centres. That was the feasibility component. And we set targets that we expected to retain at least 95% of patients in the trial at 1 year, and also that at least 75% of patients would still be taking at least half of their allocated trial drug over the year. And we chose those numbers because it's important to retain patients in trials. And if you're going to be losing patients, then it means the trial becomes very hard to interpret. And also, we argued that taking some of the drug was better than taking none of the drug. So at least if people were able to take half of our trial dosage, then that was probably better than taking none of it. So that's where we got those numbers from. And so obviously the trial ran into COVID, and like much other research, it had to stop for a while for regulatory reasons. So it stopped for a number of months in 2020. And then when it restarted, it restarted, and it was quite slow because, obviously sites were busy coping with COVID and so on and so forth. Anyway, we got to 363 patients, and that was in May 2021, and decided that, that was close enough to 400 to be able to demonstrate the feasibility element. And of the 363, we were able to retain 358 in the trial. So we were over our 95% keeping patients in the trial test. And of those, 86% were taking at least half of their allocated dose. So we also met our tolerability target. So it looks like the trial is feasible. We can recruit the number of patients that we need. We had 26 centres altogether. And had we not hit COVID, we would have finished sooner. And I think we would have met our 400 without any difficulty. So that was the feasibility side. On the safety side, there were very, very few patients who died or had a hemorrhage. There were only 4 in the entire trial who died, and only 4 who had a hemorrhage. So we were well below our safety cutoff level. So that was very encouraging. And in terms of the proof of concept efficacy, what we did was analyze each drug individually and then both drugs combined. And when we looked at each drug individually, we found that isosorbide mononitrate was trending towards reducing this composite outcome, which Philip has described, but didn't meet statistical significance. However, within that composite, isosorbide mononitrate reduced recurrent stroke. So recurrent stroke was much lower in the isosorbide than in the no isosorbide group. It also reduced cognitive impairment. It improved quality of life, and it improved a number of other outcomes which were all consistent with that sort of pattern, and it trended towards reducing dependency. When we looked at cilostazol on its own, so cilostazol versus no cilostazol, again, it didn't it didn't reduce the composite outcome according to conventional statistical thresholds, although there was a trend in that direction. However, it did reduce dependency. And then when we looked at the combination of the 2 drugs, we found that those effects were largely protected, and actually in some cases were actually made even better when the 2 drugs were used together. So the 2 drugs together reduced this composite outcome. So there were fewer combined, deaths, recurrent stroke, heart attacks, cognitive impairment, or dependency. And then within the individual outcomes, there was less dependency, less cognitive impairment, better quality of life, and a number of other, outcomes that we looked at, all consistent with that sort of overall pattern. So this is very encouraging. And we're going on now to do a larger trial to try and confirm these findings. But it would suggest that this idea that you attack 2 parts of a pathway, so one drug increases nitric oxide by giving nitric oxide, the other drug helps to stop the breakdown of the cyclic AMP, which helps to keep the blood vessels nice and healthy. They're acting on 2 parts of a pathway and then maybe acting together to give this impression of a better outcome when you use the 2 together. However, we have to emphasize that, LACI-3, LACI-2 was not planned to demonstrate benefit. It was planned to show that it was possible to do a trial like this. So we have to be quite cautious. We've looked at the data in a number of different ways to see if we can find any reason, other reason to explain these results, like some bias in the way the data were collected or anything like that. And we simply haven't been able to find any alternative explanations. So we think it's important to go on and do a larger trial to confirm these findings. But they do seem to be quite encouraging, that this approach to tackling the lining of the blood vessels, the endothelium, may be quite beneficial in this group of patients.
So I just emphasize that it wasn't a phase 2 trial. As Joanna said, it wasn't really designed for efficacy. But the efficacy findings are consistent. They're internally consistent. All the measures we made were all moving in the right direction, or a good direction, and some of them were significant. And for the combined drug group, the people who got isosorbide mononitrate and cilostazol versus neither, it's worth remembering that those almost universally were statistically significant. And of course, that's only half the population, because you're not including in that comparison the people who only got one drug or the other drug. So those are really quite powerful findings to be made in an even smaller population. But of course, we're not making claims here. We're not trying to say that everybody should be on cilostazol and isosorbide mononitrate. This is typical phase 2. We need to go and do a big study to prove once and for all that these drugs work and ideally work together. These drugs are not just available; they're pretty inexpensive. So if LACI-3 first of all is funded and happens, hopefully it will, because it's a powerful story so far. But if that trial then is positive, these drugs could be started tomorrow. I mean, obviously, things never happen quite that quickly, but they're not expensive. They're not going to break the health service, or indeed any health service around the world. They're available. They're made by generic companies, so we're not dependent on just one drug company. They appear to be tolerated and without much in the way of side effects. They appear to be safe. So if all those findings carry forward, this is something we could start very, very quickly. And as Joanna said, it's on top of existing therapy. And that's also very important, because often if you've got a condition and you've also got existing therapies, then it's more difficult to show that other things affect the outcome, because some of the benefit has already been taken up by the existing treatments. So the fact that we can add stuff to that and potentially further improve outcomes, reduce events, in this case, reduce cognition, cognitive impairment and dependency, then that's pretty powerful stuff. And I think that would be very persuasive to people around the world.
A couple of other things just to add to that. So this, if it's true, if it's confirmed in LACI-3, will be the first time that cognitive impairment after stroke has been reduced by a intervention of this nature. So that's really important. The second thing is that lacunar stroke is part of a spectrum of a condition which affects these small blood vessels in the brain called small vessel disease. And some people who have abnormalities in their small blood vessels don't get a stroke. They might develop cognitive impairment, or they might have mobility problems, or they might go for a scan for another reason, and the scan shows these abnormalities in their brain. And that's something that's called covert. It's kind of not that it doesn't have any symptoms at all. It's just that it doesn't have these typical cognitive or stroke symptoms, which are easier to recognize. And if these drugs work in LACI-2 and are confirmed in LACI-3, then there's a strong argument for also testing to see if they might help reduce cognitive decline or mobility problems, or the development of a stroke or cognitive decline, etc., in patients who have other clinical presentations of small vessel disease. So that's the first thing. And the second thing is that there's actually a number of other drugs already in circulation for other purposes, maybe without quite so much information as there was for isosorbide mononitrate and cilostazol, but nonetheless, which have some relevant potential effects on the endothelium, and would therefore also be worth testing in trials in lacunar stroke or other manifestations of small vessel disease. So there's some quite big implications for making better use of existing drugs, or at least testing them, and also for rolling out a potentially beneficial approach to improve the health of the endothelium to people who have other presentations of small vessel disease.
So just to expand on that last point, potentially there's a second trial, not just Lacunar 3, or actually there's another 2 trials. One is a trial that picks up on Joanna's point that what about people who present to a memory clinic or a falls clinic, or who have an incidental CT scan or MRI scan, perhaps for headaches or whatever? What do you do with them? Could we randomize those people with small vessel disease? But the third group is, what about other sorts of stroke, not lacunar stroke, but large artery stroke, people with embolic strokes of unknown source, so-called ESUS, cardioembolic stroke, even intracerebral hemorrhage. They also can have small vessel disease. Indeed, many people with intracerebral hemorrhages, we believe that is due to small vessel disease. So another trial we're working up would randomize them. Might have to have a different design for some of those groups of patients. You might not give cilostazol to people with a hemorrhage because it does have mild antiplatelet effects. You might not give cilostazol to people with embolic stroke due to, say, atrial fibrillation, because they're likely to be on anticoagulation. And obviously anticoagulation and a mild antiplatelet might further increase the risk of bleeding that is already present for anticoagulation. So that trial might be a little bit different. I think the patients with large artery disease and so-called ESUS could be randomized to both isosorbide and cilostazol, because there they look, at least in terms of therapeutics, they look very similar to the Lacunar group. So we're not just thinking about LACI-3, we're trying to think about how do you get to these other 2 groups of people with other sorts of stroke and people with other sorts of, well, not other sorts of small vessel disease, but other presentations with small vessel disease.